And for our first hour, we have from the Canadian Nurses Association, Meaghan Thumath, Senior Public Health Nursing Expert, and Lisa Ashey, who's a Senior Nurse Advisor, Policy, Advocacy, and Strategy Branch of that organization. From the City of Vancouver, Councillor Carrie Jang. And from the province of British Columbia, Dr. Perry Kendall, the Provincial Health Officer, and Clayton Pecknold, Assistant Deputy Minister and Director of Police Services, who are both joining us via video conference from Victoria. Thank you all for being with us today. I'm going to begin with opening statements with our witnesses in the room, beginning with Ms. Ashey, then we'll move to Mr. Jang, and then we'll move to our witnesses from British Columbia. Ms. Ashey, the floor is yours.
Thank you very much, Mr. Chair, and good afternoon, Honourable Chair and members of the committee. As you know, my name is Lisa Ashey, and I'm a registered nurse, and I work at the Canadian Nurses Association, and it's the national professional voice representing more than 139,000 nurses and registered nurses and nurse practitioners across the country. And I'm pleased to be here today with Meaghan Thumath, who is from the BC Centre for Disease Control. She will be able to answer questions that are more technical in nature. At the outset, I'm pleased to inform the committee that CNA is supportive of this important bill, particularly sections whereby it has removed many of the 26 procedural barriers for opening a supervised consumption site. Registered nurses and nurse practitioners know the impact of problematic substance use. We see it in our communities, in our clinics, and in our emergency departments. Public health nurses have been integral in pioneering Canada's supervised consumption sites, evidence-informed programs which improve access to care, improve health outcomes, reduce overdose deaths, without increasing substance use rates, community disorder, or crime. I will now turn to our suggestions, which include straightforward amendments to the bill for the committee's consideration. They are also outlined in our brief, which has been submitted to the committee. First, there is a need to remove additional procedural barriers to opening supervised consumption sites. While the current version of the bill removes legislative barriers to opening supervised consumption sites, amendments are needed to provide a more immediate response to overdose epidemics. We recognize that the proposed legislation reduces the exemption criteria from 26 to 5, a change that decreases barriers to obtaining an exemption to operate a supervised consumption site. However, the application process will still require significant time and resources on the part of medical officers of health, healthcare providers, community organizers, and individuals whose time and resources are already stretched and better applied to providing services to those who need them. This added step leaves health service providers with two unreasonable options: either A, delay the provision of life-saving services while an application is underway, or B, proceed without the exemption and face possible criminal charges. CNA puts forward the following two recommendations to address these procedural barriers. Recommendation 1, to be more responsive during developing situations such as the current opioid crisis, CNA recommends that Bill C-37 be amended to include a provision that would allow provincial or territorial ministers to grant temporary exemptions to supervised consumption sites. Recommendation 2, our position is that of the 5 proposed requirements, the sole criterion that needs to be considered is 56.12b, quote, the local conditions indicating the need for the site. This proposal aligns with the federal government's recent commitment to treating drug use as a public health issue rather than a criminal justice issue. It also reinforces the role of harm reduction as a key component of Canada's new federal drug strategy. CNA believes that if 56.12b, quote, local conditions indicating the need for the site, is met, the minister may then consider whether the regulatory structure and under 56.12c and resources and under 56.12d are in place to support the site. Still, an absence of regulatory and resource requirements should not invalidate the application. Rather, it should only serve to indicate the community's potential need for support in meeting them and assisting in government planning. Further, it is CNA's position that 56.12a, the impact of the site on crime rates, and 56.12e, expressions of community support on opposition, should also be removed. Such requirements are not supported by evidence and as such would be contradictory to the federal government's intention under the Canadian Drugs and Substances Strategy that drug policy decisions be rooted in strong evidence base. CNA recommends the amendment of existing exemption requirements under 56.12 by offering the following proposed wording. An application for an exemption under subsection 1 shall include evidence submitted in the form and manner determined by the Minister of the local conditions indicating a need for the site. Before closing, I must emphasize that CNA is a strong advocate of harm reduction, which we view as an essential part of a comprehensive health care response, which complements abstinence, prevention, and treatment strategies. I thank the committee for providing the Canadian Nurses Association with the opportunity to speak on behalf of registered nurses and nurse practitioners. We have a professional responsibility to advocate for improved access to life-saving services that are based on current evidence and research on behalf of all people of Canada. Thank you.
Thank you all for your presentations. And my first question is to the Canadian Nurses Association. I note that in both your written and oral presentation, you make two recommendations, one of which calls for empowering provincial and territorial ministers to grant temporary exemptions to supervised consumption sites. My question is this: have you had an opportunity to discuss this recommendation with either the Federal Minister of Health directly or with her provincial counterparts?
No, we have not. However, we have been working with the providers who are actually working with those federal and provincial ministers in order to ensure that this is the direction that would help to ensure that we're actually responding to public health crises as they occur.
Great. I would just add, as a registered nurse that's also worked at both Insight and some of the overdose prevention sites that Dr. Kendall mentioned, some of these were scaled up within 24 hours, and it really, on the front lines, as someone that works in the downtown east side, I can tell you it's critical that we're able to respond and have supervised consumption sites available and targeted in hotspots where we know we've had many deaths. And so this flexibility in working with our provincial Minister of Health, which certainly in British Columbia we've had the opportunity to discuss, has been absolutely crucial and has saved many, many lives.
Last July, the Federal Minister of Health signed an interim order allowing naloxone, which can either stop or reverse the effects of an overdose. I understand that it's now available in Canada in a nasal spray form on a temporary basis. And prior to this interim order, it was only allowed by way of injection. So my question is this: as this new measure being effective in either stopping or reversing the effects of an overdose?
Absolutely. The injectable formulation is very critical for non-medical first responders that don't typically have training in terms of giving injections. It's been extremely helpful, although I would say the cost is still quite prohibitive to scale it up everywhere. So in sites where we have folks who are able to give injections, we continue to use the injectable naloxone. But both measures have been absolutely life-saving.
In each area that there is this kind of center, do you think there should be some kind of official group that represents them and speaks to the center?
Association, certainly our response is when you're looking at any municipality, they have a number of community consultations that are already set up within bylaws for any new services that go in. So if you're looking at this from a public health perspective, this is no different than setting up a diabetes clinic in a certain community or anything like that. So the community does get consulted, and there are services in place for that.
It's part of our municipal charter.
Yeah.
If you could please explain why you don't think it's necessary to consider the impact of the site on public safety and security when considering a site application. What about concerns from the local government, police, or the community?
So as we were all saying, and I believe you heard that, thank you, Senator, for that question. There's two parts to your question, so I have two parts to your answer. We know that crime rates do not increase, so the public safety is not a concern. This goes down. the public concern. If you look at it from I did compare it to a diabetes clinic, you're looking at a public health intervention. You're looking at people who are then able to get health and social service referrals. They're able to go to treatment. They're able to go to detox centers. They may move to abstinence. They get housing. So from a health perspective, this is the same as offering any other situation. It is not a site where, while people may be having supervised injections, they are actually having that support of health providers near them that are able to improve their health and wellness.
Okay, so the second part of my question about you don't think it's necessary to consider police concerns, public concerns, local government, that sort of thing?
Well, no, we do, and what we've said was that municipal bylaws already have those sanctions in place where people can consult. We know that
But that's
police
potentially leaving it as a very, could alter from place to place, right? Some places might have strict municipal bylaws, others might have very lenient ones. And in our previous Conservative government's legislation, there were 26 different criteria.
Mm-hmm.
You're proposing that it basically be limited to one.
Mm-hmm.
You think that municipal bylaws alone are sufficient to take all of those things into account?
I'll answer it and then I'll move it over to Meaghan because she can give that a real life experience. But certainly we know from evidence that that is not the case, that you do see a reduction in crime and that there are consultations. I can't speak to the municipalities and what they do.
Yeah, thank you very much for your question, Senator. I think with respect to the previous Respect for Communities Act, we found that was too restrictive, and there was really no new supervised consumption facilities opened under that act because it took binders, and I think for our particular program, I think we spent 6 months preparing an application, and that's 6 months of policymakers, registered nurses like myself, physicians' time, and others, lawyers. It was an incredible expense in order to prepare an application while we were having 922 British Columbians, my friends, my colleagues, my patients die. And so we're really here before you today to say this is an urgent public health crisis, and we think that we're here in support of Bill C-37, and we also think we need to trust municipalities and provincial governments, and that we have asked for local conditions indicating the need for the site, and those local conditions, of course, include community support, including the demonstrated public health need, but we're asking for the bill to be sort of something that's simple and really easy so that we can create these life-saving public health interventions.
Senator Boniface.
Yes, thank you very much for being here, and congratulations on the effort. I can't imagine how difficult it must be, but I really appreciate you taking the time to be here, to all of you. I want to talk a little bit about the impact of the site on crime rates as one of the criteria, and I think both Ms. Ashey and Councillor Jang question whether this is a valuable criteria. And so is there, in Dr. Kendall's comments, had it actually reduced social disorder? So I'd just like to have some feedback on that because, as you can appreciate, that's one of the issues that people are most concerned about.
Do you want to go ahead?
Sure, I'll go first. Thank you very much for your question, Senator. Yes, evidence has shown, and we'd be happy to share it with committee, that has shown that actually crime rates are reduced. People are starting to get the social and health supports that they need. So there is evidence to show that crime rates do not go up.
Yeah, we see this in Vancouver police data. We track this on a weekly, monthly basis, and we've seen that we have not seen increases, and as I pointed out, things like break-and-enters and those types of other crimes have actually been reduced.
Mrs. Ashey, you wanted to add to this?
Yes, thank you. Certainly, yes, there have been systematic literature reviews that have pulled information from across the world, actually globally, that have been peer-reviewed. There's been research as well in The Lancet, which has spoken to. And for Insight specifically, it has demonstrated increased clinical visits, overdose interventions, referrals made to social and health service agencies. The vast majority rate at on-site of the latest I read was 54%, I believe, so quite high.
Mm-hmm. Could you circulate that? I see that your
Yes.
colleague, Mrs. Chuma, was
Absolutely, yeah.
waving the...
I have the paper, by Dr. Wood and several colleagues, so we'll follow up and make sure we get that to the committee. And I can just say, as a registered nurse that's worked at Insight, one of my main roles, and there's a common misconception that after someone overdoses or that attends, we just leave them and send them back out on the street. But in fact, I can assure you that we meet with them. We have a clinical room there. We provide actually full scope primary care. We have HIV testing, and we make a huge effort to connect that person to care and treatment. And so a big part of my role was actually accompanying them to detox facilities and even accompanying them to long-term treatment referrals. We have a staff dedicated to ongoing treatment referrals. So it's certainly a huge part of our role and a huge part of the continuum of registered nurses.
May I, another one? Very short.
Very short. Very short.
What's the percentage of Aboriginal people that might be, coming to your service?
It's quite high. It's definitely very overrepresented, much larger than the typical British Columbia population. I believe it's in the 60 to 70% range in the neighborhood. I don't know if Perry or Carrie want to correct me.
Perry would probably have that statistic.
Not exactly along those lines, but picking up on some of that. Have you, in terms of arguing for a more comprehensive approach, have you looked at some of the approaches, given that you've linked it already to crime rates, and I appreciate your response to colleagues, have you also looked at the long-term human, social, and fiscal costs of the sorts of approaches that are being taken now, including how much more could be saved in terms of human life and social costs and fiscal costs if, in fact, you took a more radical, progressive approach?
Yeah, thank you for that question. We've been speaking a lot about supervised consumption and its role in preventing overdose, but another area is hepatitis C and HIV. And so we know that each HIV infection costs between $200,000 and $300,000 per person for their lifetime. So that's certainly something that's borne out in the Insight evidence that we've been able to avert HIV and hepatitis C infections. And then I would also point you guys to the evidence which we'd be happy to provide around Crosstown Clinic, which was previously known as the Naomi and the Salome trial. So that might get at some of Senator's comments around prescription heroin.